as possible. And now we will shift to next speaker, Professor Mohammad Zilili. Please start sharing your screen.
Hi, everybody. It's my pleasure to be with you on this very nice symposia on spine surgeons. Thank Atul for presenting us very interesting results. My talk will be dealing with a very popular subject, dynamic fixation or mobility preserving surgeries. Is it a fact or fiction? Yeah, because sometimes some new concepts are introduced, but then they fade by the time, and then the real indications and contraindications are set up. Yes. This is my presentation order. Is there a problem with dynamic fixation? What are the type of mobility preserving surgeries? Aim of the mobility preserving surgeries? Evidence in the literature and conclusions. Is there a problem? To me, there is a real problem because those mobility preserving surgeries claim that fusion surgery, which is classic for many years, must be changed. And mobility preserving surgeries need new implants and approaches, some of which have more risks and complications, and they are expensive, and the company campaigns and supports shadow the real results of those surgeries. If you look at the PubMed search, this is a very recent search, you can find almost 20,000 hits for lumbar fusion, similar amounts, 18,000 lumbar fusion surgery and spine fusion. However, for arthroplasty, disc replacement, lumbar artificial discs, the numbers are very, very small. So then our information is not big with mobility preserving surgeries. So, what are the types of mobility preserving surgeries? There are many types actually. One is the total disc replacement, another one is the nucleus replacement, interspinous distractors, posterior dynamic instruments, and facet replacement devices. Total disc replacements has been popular in cervical spine, especially in cervical spine. Nucleus replacements have been unsuccessful, and they are no more in the market. Interspinous distractors are still popular, but they are not much used as it is before. Facet replacement is not approved by the FDA and still experimental, and probably posterior dynamic instruments are on the market. There are many types. Cervical arthroplasty is easy and popular. However, lumbar arthroplasty has started before cervical, and since it needs a major anterior surgery, it has lost its popularity. So indications are not clear, and there are problems with cost efficacy ratio. I don't know if all the young surgeons remember those devices, PDN, prosthetic disc nucleus, or there were nucleus implants, nucleus and others. However, they faded by the time. Randomized controlled multicenter studies were lacking. Implant movement were still a major problem, and because of implant movement, reoperation rates has reached up to 20 to 30%. PDN, prosthetic disc nucleus, and NUBAC device have been removed from the market. There is no more. What about interspinous distractors? There were many types, and some types were be able to be placed by a minimally invasive technique, even under local anesthesia. What were they trying to do? Since canal narrows during extension or walking, interspinous distractors are widening the canal, and they could be effective in moderate spinal stenosis patients. However, their current popularity is not like before. What about posterior dynamic instruments? Probably the first types were from Dynesis or Isolog. The companies are those. They had basically they had two types: ligament-based systems or screw-rod-based systems. The graph, Dynesis, and fast systems were real dynamic stabilization. After placing pedicle screws, you were connecting the screw heads with some ligaments. So they were not torn out during flexion extension. They were partially restricting the flexion, especially, and not restricting rotational movements. However, screw rod systems are restricting more rotational movements and allowing less flexion extension. These are some examples of ligament-based systems, and these are some examples of rod-based systems. Facet replacement, one was TAP system, total facet arthroplasty, removing all the facet and as for posterior elements, and then placing something like a amortizing implant on the back of the spine. If you look at the current condition, total disc prosthesis, especially for cervical spine, is in clinical usage. Posterior dynamic stabilization is also in clinical usage. Interspinous distractors are fading. Prosthetic disc nucleus facet replacement are not on the market, and the annulus replacement and repairs and some others are experimental. The companies are still trying to implement them in the clinical usage. This graph is from a company report which was claiming that the severity of treatment will be changed by the time, and those fusion cases will be replaced by total disc replacement or some mobility preserving surgeries. They wish this. What is the aim of mobility preservation? If you look at the aim, the main reason is that the adjacent segment disease. They claim that those surgeries will diminish adjacent segment disease. And another claim is that fusion surgery has more complications, and those surgeries create less complications. So then the other questions arise. Do those surgeries really prevent adjacent segment disease? Do hydroxyapatite coated screws really prevent metal fatigue? Because they had some analogy with the other joint arthroplasties, like hip arthroplasty or knee arthroplasty. But the spine is not a real joint like hip or knee. Why they prevent rotation, not flexion extension? Why dynamic implant, very heterogeneous groups? And what are the indications? Actually, disc herniation, listhesis, deformity, one level, multiple levels, and do we have high-level studies and high-level evidence? So the critics are timing, indications, complications, cost-effectiveness ratio, and high-level evidence studies. If you look at that phases of Kirkcaldy and Willis about the degenerative diseases, there is dysfunctional phase, instability phase, and stabilization phase. And those mobility preserving surgeries are against the natural process of the degeneration, because mostly they end with a stabilization phase or a fusion. So fusion surgery correlates to natural process. However, dynamic fixation is against the natural process. Is it possible? What is the timing? If the dynamic implants in long term, if they result with fusion, it's an expensive and useless technique. If no fusion, it's a biomechanical disadvantage. Actually, we know, especially in cervical arthroplasty, the heterotopic ossification, the body tries to fuse that level, although you place a mobilization at that level. So the stepwise treatment, which was tried to be suggested to us by the companies, the compassion, mobility preserving, and then fusion, is not working for the natural process. This study, which is a systematic literature review, looking for the dynamic or hybrid lumbar spine stabilizations, says that they can have advantages in certain indications. However, those are the cases with moderate degeneration and new onset instability. Still, higher quality studies are necessary. So then it doesn't conclude with that dynamic fixation is very useful. And probably according to that concept, we can have cases of lumbar degenerative diseases making just spinal fusion, or a part of it may turn to mobility preserving surgeries. What are the complications of mobility preserving? As I mentioned before, heterotopic ossification is one of them. The body itself defenses against preserving the mobility. Screw loosening and breakage. Although you use hydroxyapatite coated screws, doesn't matter, it may happen. Compression, dislocation, wear debris, and osteolysis are some other complications of those. And at the end, although you place a dynamic fixation, with the heterotopic ossification, a fusion may happen. In this study, 126 patients, 19.8% of the screws have loosened in 25 patients. This is one example of my observations. This is one of my cases. She had a young female patient. She had a L5S1 dynamic fixation, axial pain since 2009, and on the direct radiographs you can see easily a halo on the S1 screws. Yes, although one of the screws is not properly placed, it is on the ala, not going to the promontorium, but screw loosening is here. What did I suggest? First, injections. If they don't get any benefit, then fusion surgery may be offered. What about this case? 71 years old male, two-level dynamic fixation, leg pain resolved. However, he came back 2 months later with back pain, and you can see an adjacent level disease at this patient. So, although they claim that adjacent level disease will be prevented, it has happened with 2 levels. So, critics, failure of fixation without fusion is well known for many years. We must never forget the fact that those patients get more pain 3 to 6 months later. And should we consider all fixations without fusion as dynamic fixation? Actually, nowadays, since fixation devices are very popular, we see more and more non-union patients, and we revise them. And the same can happen with the dynamic fixations. What about the evidence in the literature? This is more important than anything else, probably. This study is saying that instrumental levels carry the loss. This is not true for dynesis and rigid fixation. This is the same. Instrumental levels carry the loss. This study from 2007, dynamic implant does not necessarily reduce axial spinal loss compared to an uninstrumented spine. They allow some controlled movement. Yeah, they can, but problem is how will the surgeon decide? What is the optimal range of motion permitted, best fitting for individual patient, and how will he or she choose which implant is the best? This is still not validated even by biomechanical studies. They reduce degeneration in the adjacent segments. As I have shown the example, it's not true. Incidence in cervical spine is about 3%. Incidence in lumbar spine 2 to 14% adjacent segment disease. Are we talking about 3% incidence to lower this number with new implants and very costly, expensive implants? It's interesting. Yeah. Another thing is that adjacent segment disease the etiology is multifactorial, and there are various reasons other than fusion of the motion segment. Injury to the posterior ligament complex, sagittal imbalance, lacking awareness of the lordosis of the lumbar spine or cervical spine. Such things may also cause adjacent segment disease. There are studies that for cervical arthroplasty, for instance, these are studies from 2012 and others, which is telling that the arthroplasty reduces adjacent segment degeneration. However, this meta-analysis from 2012 is saying that with current evidence, we cannot conclude that cervical disc arthroplasty significantly reduces the postoperative adjacent segment disease. There are some studies, yes or no, like this study from 2012. Not all the studies are blinded, saying 8 out of 9 studies are company supported and maximum 1 to 2 years results. Actually, these authors have telling that all those cervical arthroplasty IDE studies have been done by persons who already use cervical arthroplasty in their practice, and that they like it. So there are still bias for using them. Do they this is again no, saying for lumbar spine, dynesis could provide sufficient stabilization in degenerative instability. However, movement in adjacent segment is not different than rigid fixation. And these two studies are graft ligament is not successful. In Vaccaro's paper, which is trying to summarize those in 2009 to draw some conclusion that a posterior dynamic device is better than fusion, results from multiple similarly designed independently funded trials must be compiled, compared, and contrasted. This 2015 systematic literature, very large series, and there are 4 studies from my country with Dr. Fahir Özer and his group. Actually, they are telling that it has no apparent difference in prevention of adjacent segment disease. And dynamic stabilization can have advantages in selected indications. Those are medium level degeneration and new onset instability. They should not be used in very elderly patients. Another one, dynamic fixation with Coflex, 2018. Coflex treatment can reduce the influence on adjacent segments and delay degeneration. But that is all. Let's skip some of them. And this is with interspinous device, DIAM and interspinous U, 5 years follow-up, and saying that this reoperation due to severe back pain is about 16% in interspinous U, with the DIAM 28%, very high level. The new concept is that topping of implants. Actually, you can use rigid fixation with fusion for some levels, but for the other level, mostly upper level, to prevent adjacent level disease, a top of implant with mobility preserving device like this, dynesis screw, transition screw. So-called hybrid fixation, ASD incidence is 4.76%. So this is another topping of implants paper, 22 patients. ASD of the segment cranial to the topping off is 3 cases, lower. So it has gathered more popularity recently. Yeah. Yes, this is with 3 groups, with topping off using dynamic screws, topping off using interspinous process devices. So this is another study. At the index level, the effect of hybrid stabilization device or interspinous process device for decreasing ASD have been found similar. Again, another topping of implant paper. This 22 recent paper, in current conditions, we cannot conclude that dynesis dynamic stability is superior to fusion surgery in lumbar degenerative disease. So, if you look at the evolutions of them, first devices were ligament-based, then rod-based, semi-rigid dynamic fixation, then peak rods have been used, but there have been some breakage of the peak rods, so they are not as popular as before. So the recent trend is a hybrid fixation and topping of implants. So, as the WFNS Spine Committee, we recommended that mobility preserving surgeries is not the only way to prevent adjacent segment disease, and we said that decompensation is the basis of surgical treatment for lumbar spine stenosis, and adjacent segment incidence can be decreased by applying other measures, not just mobility preservation. In conclusion, for lumbar spine stenosis, still not a role. Is there a role of dynamic fixation? Outcomes are similar, benefits are not as presumed. New shift to hybrid fixations or topping of devices should further be evaluated. Do dynamic fixation implants prevent adjacent? Yes, they may prevent adjacent segment disease, but if it is really necessary, long-term and multi-center controlled trials are necessary to really believe that concept. And fusion is still a gold standard in lumbar degenerative diseases. Among well-selected patients, it gives effective and continuous results. Fusion surgery has two main critics. One is the non-union pseudoarthrosis and adjacent segment disease. However, mobility-preserving surgeries can have wide application. Although they can have wide application, there are many techniques. Evidence-based medicine does not support them very well. There is still a big lack of level 1 and level 2 studies. And most studies are done by surgeons who use those implants. And the main objective, it reduces adjacent segment disease, has not proven yet. They are expensive devices. To prevent adjacent segment disease, we can apply minimally invasive surgeries. We can apply protection of muscles and ligaments. We must use short segment fixations instead of longer segments, preserve low doses, and SVA must be less than 50 millimeters. And answers for timing, as I mentioned before, indications not clear, it must be in the early phase of instability. Complications, in contrast to their claim, they have more complications, especially screw breakage and loosening. Cost-effective ratio is worse, more expensive. Okay. And in general practice, many cases operated for fusion, but without trying placing a good fusion bed and placing good enough grafts, they can also be considered as dynamic fixation, and their results are not good, and they commonly need a revision surgery. This is probably the indications, although they were telling such a large indication at the beginning, probably their indications must be confined to that smaller area. Thank you for listening to me.
Thank you, dear friend, for this excellent and